In the name of God, no, I want to talk about the joints of lower limb. As you remember, the first of all, I started by summary of the joint classification. You read the joint classification in upper limb, but for the short review, I write one table in here. You can see that we classificate the joint with three types: the fibrous, the cartilaginous, and synovial. The fibrous, it means that the tissue between the two parts of the bone is joined by a fibrous tissue or collagen fibers. And we have a three type of the fibrous, as you know: suture, like a suture between the skull bones, for example between the parietal and occipital bones; syndesmosis; and gomphosis. The syndesmosis, like a interosseous membrane in the radius, and ulna or interosseous membrane between the tibia and fibula. The gomphosis, again like teeth and upper jaw and lower jaw. And the fibrous joints usually is immobile, slightly movable, like amphiarthrosis, and immobile. And totally, in conclusion, they are immobile. If you look at the skull bones, for example occipital and parietal, we don't have any movements. The cartilaginous, the bone ends unit by cartilage; synchondrosis and symphysis. For example, the synchondrosis in epiphyseal plate in the long bone, the epiphyseal plate situated between two parts of the bone, and this is a synchondrosis because the two parts of the bones joined by hyaline cartilage. And symphysis, the two parts of the bone joined by the fibrocartilage, like a symphysis of pubis between the body of two pubis, or the intervertebral disc between the body of the two vertebra. Usually has a slightly movable. But the synovial joints, today I want to talk about the synovial joint, especially in the lower limb. As you know, the bone ends covered by articular cartilage and enclosed within the capsule lined with a synovial membrane. They have a freely movements. Usually we say that freely movable, and which depends on the joint design. We have a sixth type of the synovial joint: plane, hinge, pivot, condyloid, saddle, and ball and socket. In this simple diagram you can see that the difference between the three type of the joint. If you look at the picture, you can see that in the synovial joint we have a most mobility, and when we go toward the suture, we have a immovable joint. Here the sutures: intervertebral disc is a symphysis, and the hinge joint, the synovial, the ball and socket in the hip joint, and the ball and socket in the shoulder joints. As you remember, we have a six type of the synovial joint. Here you can see that the plane joint between the metatarsal bones, for example between the navicular and cuneiforms. Here This is a plane. Or in the wrist, between the proximal and distal row of the wrist bones, we have a plane type of the synovials. The hinge, the best example in the hinge is the hinge joint between the trochlea and humerus. Here, between the trochlea and trochlear notch, this type is this shape is the hinge joints. The pivot joint, but again it's best example between the we have a superior radioulnar joint in the upper limbs. The condyloid joint, or some texts say that the ellipsoid between the proximal row of the wrist bone and the lower end of the radius and ulna, radius and the scaphoid and lunate bone of the corpse. The saddle joint, the best example is between the trapezium of the carpus in the wrist and the metacarpal of the thumb. We say that saddle. And the ball and socket joint between the head of femur and the acetabulum of hip bones, or the head of the humerus and the glenoid cavity in the scapula bones. Okay, this slide is just for the review. Now I want to talk about the lower limb joints. The first of all, I started from the hip joint. The hip joint is a ball and socket type of the synovial joint. It's a multi-axial. The head of femur articulate with acetabulum of hip bone to form the hip joint. You can see the shape of the joint, the head of femur with the acetabulum fossa of the hip bones. The head of femur forms more than half a sphere and is covered by hyaline cartilage except at the fovea capitis. This is a fovea capitis, do you remember? The acetabulum presents a horseshoe shaped lunate articular. This is a lunate surface of acetabulums. And the acetabular fossa, the lunate surface is covered with cartilage, though the articular surface of the head of femur and the acetabulum are reciprocally curved. They are not coextensive. The hip joint is unique in having a high degree of stability as well as mobility. The stability or strength depend on depth of acetabulum and narrowing its tension and strength on ligaments, strength of surrounding muscles, length and obliquity of the neck of femur, and atmosphere pressures. The first of all, I want to talk about the capsules. The hip joint is enclosed with strong fibrous capsule lined by synovial membrane. The proximally here, the capsule is attached to the acetabulum and transverse acetabular ligament. Distally, anteriorly covered the neck and it attached to the intertrochanteric line in here, and posterior cover medial half of the neck of femurs. This is a capsule. The green color is a capsule of the hip joints. In the hip joint we have some ligaments, fibrous capsule, iliofemoral ligaments, pubofemoral ligaments, sciofemoral, and ligament of head of femur. The ligament of femur, head of femur, is a intracapsular ligaments. You can see here, this is a capsular ligaments. If you look at the picture, you can see that the ligament of head of femur or tres ligaments, this one, some texts say that the tres ligament is attached to the fovea capitis from the one side, and another side attached to the transverse acetabular ligaments. The tres ligament or round ligament of head of femurs. The iliofemoral ligament and ischio and pubofemoral ligaments, both of them situated in the anterior view of the femurs, and the ischiofemoral ligament situated in the posterior view of the femurs. You can compare the position of these ligaments. This is an anterior view and this one is a posterior. Anterior again is a posterior view. These three ligaments are extracapsulars. Okay? The pubofemoral ligament, this one, pubofemoral ligament, the green color in these pictures, pubofemoral ligaments suppose the joint inframedially. It's also triangular in shape. Superiorly is attached to iliopubic eminence, obturator crest and obturator membrane. Inferiorly it's merged with the anterior inferior part of the capsule and with the lower band of iliofemoral ligaments here. This is a superior attachment, as I told you, is attached to the iliopubic eminence here, iliopubic eminence, obturator crest and obturator membrane, and inferiorly it's merged with anterior inferior part of the capsule of the joint and lower band of the iliofemoral ligaments. The another one, iliofemorals. Iliofemoral is like an inverted Y shape. It's one of the strongest ligament in the body. It prevents the trunk from falling backwards in the standing posture. Is important function. The ligament is triangular as you see in these pictures. The apex is attached to the lower half of anterior inferior iliac spine. Here is a anterior iliac inferior iliac spine, and the base to the intertrochanteric line, this one. The upper oblique and lower vertical fiber from thick and strong bond, while the middle fiber are thin. Okay, another one is ischiofemoral. These pictures, the ischiofemoral ligaments is comparatively weak. It's covered the joint posteriorly. Its fiber are twisted and extended from ischium to acetabulum here. The fibers of the ligament from the zona orbicularis form zona orbicularis. Some of them are attached to the greater trochanteric, of femurs. Okay, this is about a hip joint. The nerve supply, the hip joint is supplied by femoral nerves through nerve to rectus femoris, anterior division of obturator nerve and nerve to quadratus femoris and superior gluteal nerve. You can read the details of the ligaments here. The blood supply, the hip joint is supplied by the obturator nerve artery to circumflex femorals. You can see that this is a lateral circumflex femoral artery, medial circumflex femoral artery, and obturator artery. This is important. And about the movements in the hip joint, we have a flexion, extension, abduction, adduction, lateral rotation, medial rotation, and circumduction. And each parts, you can see that the main muscles for this action, for the main or primary movement of the flexion, it's happened by iliopsoas, is highlighted in here, and another muscles help to these muscles, but the main action is happened by iliopsoas. The extension, it's happened by gluteus maximus, but it's helped by hamstring muscles. Abduction by gluteus medius and minimus. Adduction by adductor group muscles. Lateral rotation, it's by small muscles in the gluteal region like piriformis, obturator internus, externus, superior and inferior gemili, and quadratus femoris. And medial rotation, usually it's happened by anterior fiber of gluteus medius and gluteus minimus. The primary function of the hip joint is to weight bear. There are number of factors that increase stability of joint. One of the important factors is acetabulum, because it's deep and encompasses nearly all of the head of femurs. And there are a horseshoe-shaped fibrocartilage that name is acetabular laborum. This acetabulum causes increases in the dip, provide a large articular surface, and here around the joint we have a strong ligament like iliofemoral, pubofemoral, and ischiofemoral ligaments. In addition, the muscles and ligaments work in reciprocal fashion on the hip joint. Okay, here we have some clinical point. Usually here we have a congenital dislocation is more common in the hip than in any other joint of the body. The head of femur slips upward onto the gluteal surface of ilium because the upper margin of the acetabulum is developmentally deficient. And here we have another abnormality like a coxa is condition in which the neck shaft angle is reduced from normal angle of about 150 degree in a child and 127 in an adult. And another one is Perthes disease or pseudocoxagia, in characteristic by destruction and flattening of the head of the femur with an increased joint space and X-ray pictures. Okay. The next joint, is a knee joint. The knee joint is largest and most complex joint on the body. Its complexity is a result of fashion of three joints in one. It's formed by fusion of the lateral femorotibial, medial femorotibial, and femoropatellar joints. Okay? The knee joint. Because we have a lateral femorotibial joint, medial femorotibials, and femoropatellar joints. The tibiofemoral, the medial condyle of femur and lateral condyle of the femur articulate with the tibial condyles. The patellofemoral, the anterior and distal part of the femurs articulating with the patella. Intracondylar fossa, if you remember, in the posterior view of the lower end of femur, we have one deep notch, that deep notch which divides the two condyles posteriorly. The tibial plateau, or the upper part of superior surface of the tibial condyle, you can see here. The upper part of the tibial condyles form a flat surface known as tibial plateau. These structures articulate with the femoral condyle here, and between the tibial plateau, tibial surface, in here we have intercondylar spaces that you see some structure attached to this area. The intercondylar area in the tibia give attachments to 6 structure from before backwards, because it is a anterior and here is a posterior. This is a tibial tuberosity in these pictures. The anterior horn of the medial meniscus, anterior cruciate ligaments, anterior horn of the lateral meniscus, and here we have an intercondylar eminence, posterior horn of the lateral meniscus, anterior horn of the posterior horn of the medial meniscus, and the last one is a posterior cruciate of ligaments. For memorize of these attachments, look at my pictures. Mnemonics: medial college London, London medial college, medial meniscus, cruciate ligaments, lateral meniscus, medial college London, London medical college, lateral meniscus, medial meniscus, and cruciate ligament posterior. Okay, this is important for the memorize it. The capsule is estranged by the capsular ligament, is weak but is estranged by anteriorly medial and lateral patellar retinacula, which are extension from the vastus medialis and lateralis, laterally by iliotibial tract, medially by expansion from the tendon of the sartorius and semimembranous, posteriorly by oblique popliteal ligaments. Here you can see that the joints, this is a meniscus, patellar ligaments, popliteus tendon, and this is a capsules. The cruciate ligaments, I want to talk about the cruciate ligaments. These are a very thick and strong fibrous bonds which act as a direct bond of union between tibia and femur to maintain the anteroposterior stability of knee joint. They are named according to attachment on tibia. Anterior cruciate ligament begin from the anterior, here, this one, begins from the anterior part of intercondylar area of tibia, run upward, backward, and laterally, and it's attached to posterior part of medial surface, posterior medial surface of lateral condyle of femur. It's taught during extension of knee. Posterior cruciate, this one, begins from the posterior part of intercondylar area of tibia, round upward, forward, and medially, and attached to the anterior part of lateral surface of medial condyle of femur. Is taught during the flexions. You can see here they are anterior cruciate, posterior. Anterior cruciate is lateral and the posterior cruciate is medial. Posterior cruciate ligament is larger and stronger than the anterior cruciate ligaments. These form a cross arrangement X, as these are named as. As I told you, the anterior cruciate ligaments resists forward movement of tibia and femurs, this one, because it's taught in this maneuver, and posterior cruciate ligament resists backward movement of tibia and femurs. You can see here again. This is a more details about the anterior cruciate ligament and the posterior cruciate ligaments. And stability of the knee joint. The stability of knee joint is important by cruciate ligament, as I told you. Collateral ligament maintains side-to-side stability. Capsule thickening as noted before. Iliotibial tract. Do you remember the fascia lata in the lower limbs in the lateral side? Be strong, and we say that this thickness in the fascia lata, his name is iliotibial tract. This bond plays an important role in stabilizing the knee and patella retinacula. Now I want to talk about the meniscus or menisci. In the knee joint, we have two fibrous cartilage, that name is meniscus. What's the role of the meniscus in the joint? Okay, the menisci or semilunar cartilage are flattened crescent-shaped disc, you can see here, inside the knee joint on medial and laterals, which between articular surface of femur and tibia and thickest at the peripherally. Medial meniscus and lateral meniscus. You can see the picture in anterior view and above. This is the anterior and posterior cruciate, medial meniscus and lateral meniscus. Again, these pictures. The medial meniscus is C-shape, this one, attached to the medial collateral ligaments here and interarticular area of tibia. Do you remember? In the interarticular area of, acts as a cushion or shock absorber and lubricates the articular surface by distributing synovial fluid in a windshield wiper manner. The lateral meniscus, nearly circular, you compare the shapes, nearly circular, acts as cushions and facilitate lubrications. Separate, this is important point, the separated laterally from the fibular or lateral collateral ligaments by tendon of popliteal muscle and aids in forming more stable base for the articulation of femoral condyle. Here we have the one important difference. As I told you, the medial meniscus attached to the medial collateral ligaments, but the lateral meniscus separated from the lateral collateral by tendon of the popliteal muscles. As a result of these differences, the medial meniscus, it's more susceptible, or it's the injury in the medial meniscus is more common that lateral meniscus, because the popliteal muscles the doing the pulling on the lateral meniscus, at the medial meniscus it's more injured during the accident. Okay, in the knee joints, we have some bursa around the knee joints. Some bursa, you can see one of them is infrapatellar, and this one, some bursas you can see, prepatellar bursa and infrapatellar bursa. And what's of the role of the bursa? As many as around 12 bursa have been described around the knee, 4 anterior, 4 lateral, and 4 medial. The subcutaneous prepatellar bursa, subcutaneous infrapatellar bursa, these two ones is more important than another ones. What the role of this bursa? This bursa help to the action of the tendons, especially the patellar tendons, and here we have some nerves to supply of the joint: the femoral nerve, sciatic nerves, and the obturator nerve that supply the joints. And the movement, here we have an extension that's happened by quadriceps femoris, a locking happened by vastus medialis, unlocking by popliteus, flexion by hamstring muscles, medial rotation of flex leg by popliteus semimembranous semitendinosus, and lateral rotation of flex leg by biceps femoris. And about the meniscus, injury to meniscus, strains in a slightly flexed knee, as in kicking a football, the meniscus may get separated from the capsule or may be turned longitudinally, a bucket handle tear, or the transversely. As I told you, the medial meniscus is more vulnerable to injury than the lateral, because of its fixity to the tibial collateral ligament, and because of greater excrusion during rotatory movement. The lateral meniscus is protected by popliteus, which pulls backwards so that it's not crushed between the articular surface. Injury to cruciate ligament are also common, and injury to collateral ligaments are less common. And that's all about the knee joints. And ankle joints, this is about the cruciate, as I told you, stability, the meniscus. The ankle is a synovial joint of the hinge variety. It's a type of hinge. The upper articular surface is formed by lower end of tibia, including the medial malleolus, as you see here, the lateral malleolus of fibula, and inferiorly by superior or surface of the talus here. Medial malleolus, lateral malleolus, and talus, you can see here again. Structurally, the joint is very strong. The stability of joint ensured by close interlocking of articular surface, as you see in the pictures, strong collateral ligament on the sides, and tendons that cross the joint, 4 in front, 3 on posteromedial, and 2 on the posterolateral sides. Here we have some ligaments around the joint. The joint is supported by fibrous capsule, the deltoid or medial ligament, and 1 lateral ligaments you can see here. This is a deltoid or medial ligament, it's lateral ligaments. Deltoid or medial ligaments, it's a very strong triangular ligament present on the medial side of the ankle. The ligament is divided into superficial and deep part, as you see the pictures. Both parts have a common attachment above to the apex and margin of medial malleolus, you can see here. The lower attachment is indicated by the name of fiber. The lower attachments, okay. Here this is the medial ligaments, the superficial parts. You can see that in this picture, superficial parts. As I told you, the lower attachment of superficial part indicate by the name of fiber. Anterior fiber, his name is anterior tibotalar parts. The tibionaviculars. The medial fiber tibocalcaneal. Tibofibular. The anterior part is tibonavicular, the middle is tibiocalcaneal, and posterior fiber or posterior tibotalar is not showing here. This one, tibotalars. The deep part or anterior tibotalar, deep part, this one, is attached to the anterior part of medial surface of the talus. The lateral ligaments, consist of 3 bones: anterior talofibular, this one, posterior talofibular, this one, calcaneofibular, this one. These are lateral ligaments. The movements, the active movement are dorsi and plantar flexion. This is a lateral ligament. As I told you, here we have a dorsi and plantar flexions. The blood supply is anterior tibial, posterior tibial and pronar artery, and nerve, a deep pronar tibial nerve. Here in this joint we have some clinical anatomy. Sprains of the ankle are the almost always abduction sprains of subtalar joint. Dislocation of ankle are rare because joint is very stable. And during walking, the plantar flexor rise heel from the ground. When the limb is moved forward, the dislocation help the foot is clearing the ground. The value of ankle joint resides in a hinge action in this and to and fro movement of joint during the walking. Okay, the another joint is here is a subtalar joint. The subtalar joint, you can see in here, this is a subtalus below to the talus. The subtalar joint are just two joint between the talus and calcaneus, posterior talocalcaneal, this one, posterior talocalcaneal and talonaviculus. This one, it's showing here clearly, posterior talocalcaneal and talocalcaneonavicular here, but usually in the text we say that subtalar to this joint between the inferior surface of talus and superior surface of calcaneus. The joint is classed structurally as synovial joint and functionally is plain synovial joints. This is about the deltoid or medial ligament. I told you about the medial ligament or deltoids. What's the action of the subtalar joint? The subtalar joint do the eversion and inversion. This eversion and inversion is important during the walking, and this is an important action that's happened in the subtalar joints. Okay, another joint in the foot is a joint between tarso-metatarsal joint. His name is Lisfranc. Tarso-metatarsal is a Lisfranc. The joint between the intertarsal joint, that the intertarsal joint is a plain joints, and the joint between the, you can see that here between the naviculars and cuneiform, cuboid and cuneiform and cuboid with the tarsal metatarsal bone. As I told you, his name is Lisfranc or tarso-metatarsal joint or Lisfranc. This joint is important during the amputation of the limb. Usually the clinically, if it's happen and if the surgeon wants to doing amputation, usually the amputation in the midfoot is happen in this dot lines in Lisfranc or tarso-metatarsal joints. And here we have a plain joint again. We have a small movement between the bones in here, and another joint that we have a joint between metatarsophalangeal joint here. The structure of this joint is similar to corresponding joint of the hand with two exceptions. The deep transverse ligament of foot connect all the 5 toes instead only 4 fingers in the hands. The toes are adducted and abducted with reference to the second toe and not the third finger as in the hands. It means that axis of movements in lower limb is second toe, but if you remember in the upper limb we have axis of movement, abduction is third toes. Okay, and you can see here the metatarsophalangeal joint, and finally we have a interphalangeal joint. Is not functionally like upper limbs, and that's all. And now the lower limb courses is finished. Thank you very much for your attention. Good luck.